Welcome back to Alimentos y Emociones podcast. Today we're going to talk to Dr. Laura McGowan, who is based at Queen's University in Belfast. As a psychologist, Laura's research focuses on theory-based behavior change interventions to improve diet and nutrition status and to prevent and treat obesity in a variety of population groups. Laura has a particular interest in the role of novel behavior change methods such as habit formation and peer support, and she is keen to explore dietary behavior change across the life course, including the preconception, pregnancy, and aging populations. She's a member of the Research Impact Subcommittee for the Division of Health Psychology and a committee member for the Division of Health Psychology in Northern Ireland. She's the regional lead for the Association of the Study of Obesity in Northern Ireland Network and an invited member of the Obesity Prevention Steering Group at the Department of Health in Northern Ireland. She is also an invited member of the All-Ireland Obesity Coalition, Safe Foods, and she regularly contributes to the popular press via articles and interviews. Laura McGowan is going to talk to us today about interventions across the reproductive years. Please don't forget to share this episode, subscribe to Alimentos y Emociones podcast, both on Spotify, iTunes, Anchor, or all of your other favorite podcast platforms. You can also watch this program on YouTube, and please leave us a comment and press the notification buttons. This will help us grow this channel. Also remember that on Spotify now, you can leave us some stars. This helps us to position the podcast as a way of disseminating science and help us grow our community. You can do this by entering the Alimentos y Emociones podcast profile on Spotify. Next to the bell, you will find 3 vertical dots where it says rate this program, rate us, and help us grow. Hello, everyone, and welcome back to Alimentos y Emociones podcast. It's very exciting to have Laura McGowan here with us today to talk about interventions across the reproductive years. Hello, Laura. Nice to have you.
Hello, Claudia. Thank you for having me. It's a pleasure to be here.
Well, I've known Laura now for about 10 years, so it's really good to follow your work. And just to start off with, before we, dive into the subject, which is a really interesting one, how did you get into, you're a psychologist by training, but how did you start all this work with, nutrition interventions or behavioral interventions and nutrition in this area?
Okay, yeah. So actually, right from my undergraduate degree, funny, I came across my dissertation recently in a clear out that all of the things that I've done since my psychology degree have been focused around nutrition, food, what's driving food choices, thinking about those kind of psychological factors as well that really, influence our food related behavior and to some extent some of our activity related behavior too. So I guess that kind of energy balance equation. And so yeah, I did my degree in psychology. I then went on and did my PhD in an area of health psychology, again, looking at the factors that influence adult food choice, but with a focus on the kind of psychological factors or predictors that influence that, things like self-efficacy and, understanding the role of emotion and so on. And then I took a little bit of a break after that, after my PhD, and went and worked in our kind of public health agency here in Northern Ireland. But then quickly went back into the world of academia, and that's where our paths crossed in University College London, and that was under the direction of Professor Jane Wardle at the Health Behaviour Research Centre. And I guess that was one of my first proper kind of postdoctoral roles. And that was working across a variety of different interventions, actually, school-based interventions for young children in a kind of obesity prevention context. So really trying to look at improving, behaviors related to food choices and nutrition. And that led me on to one of my, the trial that I enjoyed the most while I was in London, which was the kind of Puppets Healthy Habits trial. And that was really working with that. Yeah. So that was working with parents of young preschool age children, really to try and formulate healthy feeding habits in the parents, if you like. And then they are the gatekeepers for those young preschool age children. So that was a really interesting trial we did. And it was found to be sort of, the parents really enjoyed it. The kind of crux of the behavior change component of that trial was around habit formation. So the idea of, coming up with a very clearly specified novel new behavior in a particular feeding area. So we covered, sweet sort of foods, fruit and vegetables, and then sugary drinks in sort of 3 separate visits. And, they come up with a new habit, if you like, a new behavior that they then tried to make habitual by repeating it as regularly as possible. So daily, if possible, in a very specific context at a very specific moment of their day. So for example, always having 2 vegetables with dinner, that could have been their kind of new habit, habitual behavior that they were trying to embed. And it was really interesting. So, there were really significant changes in the children's diets. There were increases in habit strength. We measured that using a scale which measures something called automaticity. Mm-hmm. So taps into that kind of automatic nature of a behavior and kind of how much you do that sort of in a sort of semi-unconscious way. It becomes that idea of it becoming second nature. And so there was,
set up like a goal for the family, for specific families, and then they follow that goal and they try and repeat it. So they self-monitor it, they monitor it for their kid. I always say that the difference between self-monitoring and monitoring.
Yes.
And then hopefully it becomes automatic, and that's when you're measuring this automaticity.
Exactly that. So there were lots of what we would call behavior change techniques. There were lots of other behavior change techniques at play in terms of the setup of this new behavior, this novel behavior, and the tracking of it. And then habit formation, I suppose, was, can be looked at as just one behavior change technique in itself. And so, the idea was repeating it in this very specific context over time. It would then it would take on what happens is it takes on, you start to respond to the cues of dinner rather than having to remember each time, okay, really intentionally, okay, I need to, cook 2 vegetables or provide 2 vegetables with this meal. Over time, doing that, providing those vegetables with that in that setting becomes a habitual behavior. And so over time, that becomes less effortful on your part to try and remember to do that. Yeah. So it was very well received. We published that paper in the American Journal of Clinical Nutrition actually in 2013. So goodness, it was a while ago. And then really that sort of sparked my interest in terms of, these theory-based interventions and really trying to specify the mechanisms of change and understanding the behavior change techniques that are in them and so on. And then I moved back to Northern Ireland, based now at Queen's University in Belfast. And really since returning here and then becoming a lecturer here in the Centre for Public Health, I've worked on a variety of different behavior change interventions, but all have the theme of, improved nutritional behaviors. And in many of those trials, we've also embedded habit formation as a kind of mechanism for achieving behavior change.
Wow. So now so basically your core work right now, I understand, is within this whole area of the reproductive years. So do you want to sort of start us in that direction of what you're doing now, and where what you've been doing now?
Yeah. So I guess one of the things that always really interested me was around sort of young women and young adults in the kind of, I suppose, in the reproductive years. And funny, right back in my days in University College London, we published a paper, myself and my colleague Ben Gardner, with a student at the time, Charlotte Wallach, and she was looking at how young women read nutritional information and how that influences their kind of dietary choices. So I've always been interested in that. And I guess partly because I was that young in that cohort, if you like, beyond it now. And
no, you're not.
Essentially, that then kind of piqued my interest. I was working with the young children, and it's a little bit of a chicken and egg scenario. Like, I kept sort of thinking, okay, well, even though we're working with the preschoolers, like, what's the stage before that? Like, what is the earliest point that we can intervene for maximal health gain? So that took me back to the pregnancy period initially. And so I have an ongoing trial. It's a feasibility and acceptability trial called the HIPPY study for short, and that stands for Healthy Habits in Pregnancy and Beyond. And that is a sort of all Ireland trial. So we've been working with 2 sites in the north of Ireland and also 2 sites in the south of Ireland, to try and help women who enter pregnancy at a higher weight to formulate a series of kind of healthy nutrition related and activity related behaviors during pregnancy. And again, habit formation is a key kind of mechanism there. So what we did was we took some of the 10 top tips work, which I know has been discussed before, and our colleague Becca Beacon from UCL led on that trial. And that was really for adults in primary care to try and embed these 10 sort of simplistic, behaviors around diet and nutrition and physical activity to try and create a calorie deficit each day. And therefore, to try and essentially the aim of that was to reduce their weight slightly. They were adults with obesity recruited through general practice. Now, of course, with pregnant women, we aren't asking them to lose weight, but nonetheless, we did want them to improve their nutrition-related behaviours and their activity-related behaviours within the realms of what's deemed safe in pregnancy. So this trial has been really spread out across 3 phases. The very first phase was to kind of engage with these sites across Ireland, because it was a kind of cross-border collaborative European funding initiative. So we spent a long time trying to work with the partner sites to try and explore the healthcare pathways in each country, because even though we're neighbours, they're very different.
Yeah.
And then the second phase was really around adapting the previous 10 top tips intervention to make it suitable for pregnancy. And so Becca Beacon was involved in that as a co-investigator, as well as Dr. Helen Croker, and then myself and my team, and Professor Michelle McKinley, who I work with, was the PI on that trial. And we really spent a long time in that adaptation phase, and we had a significant amount of input from like what we call PPI. So, these kind of, in Northern Ireland, we call them personal and public involvement in research, but in England, it's mostly referred to as patient and public involvement. And that's the idea of having people with lived experience really integrated and part of the process of shaping your research in terms of its design, and thinking about dissemination and how you manage the data and all of that, rather than just as participants. So they're not participants, they're really shaping the design of the study. And so we've had a panel of PPI representatives that we recruited who've been really actively involved in designing the leaflet and the logbook, and looking at the images we use and all of the language, because that's another really Pardon?
The tips themselves as well?
Yeah, absolutely. Yeah. So we redesigned some of the tips, of course, to make them suitable for pregnancy. They were involved in thinking about what those tips should look like, what made sense in a pregnancy context, versus non-pregnant individuals. So that's been really helpful. And so that trial is ongoing. I mean, I have to say it's been, the world's longest feasibility and acceptability trial as a result of COVID. We were supposed to recruit women from within the existing antenatal care pathways.
Yeah.
Because really here in both countries, there is very, very little, if anything, offered by way of evidence-based interventions to help manage weight. So
during pregnancy or just in general?
Well, actually in general, but specifically during pregnancy in this context. There is a program in Northern Ireland if you have a BMI over 38, but there was a real gap for women with a BMI from 25 or more. And we really found a need through some of our kind of initial research for women to want something to kind of fill that gap. And they wanted advice in a kind of non-stigmatizing, non-judgmental way. So we've really spent a long time in this trial thinking about the way we talk about weight and, changing behaviors and trying to make sure that we reflect that, we certainly, there's no blame or judgment on those women taking part, but it's to say that, the environment is extremely complex to navigate. But if you want to make a few small changes now that you're, having a baby and so on, here are a few things that you could think about. And then, using habit formation to try and encourage some of those tips, then those 10 tips to become habitual. So that's been a really interesting one. But I guess in answer to your question of how I got into this particular field, then as a result of the pregnancy trial, I've gone one step further back again to the preconception period. So I don't know where this is going to end up, Claudia, but essentially I just keep going back.
You just get to it across the whole of the life cycle. You end up with one and then you go back and then you start again.
Exactly. And I think the thing is, from my perspective, we do need to have a suite of interventions that are evidence-based that we can use at any point in the life course. So, this trial has been really interesting. We've learned an awful lot from it. We ended up having to add a kind of an additional arm through our PhD student, Julia McClelland, to incorporate some text messaging as an additional mechanism of support and behavior change, because we ended up with COVID having to recruit through the community as well as through the healthcare services, because they were obviously crippled with COVID. So that's been really interesting, and we don't have the results just yet, I'm afraid. I was just on a call earlier, so I think we have 2 participants left that need to do their 36-week pregnancy, data collection point, and then we follow them right up to 6 or 8 weeks postpartum. So it won't be too far away, but that trial will have shown us some really interesting stuff. And in the meantime, some of my attention has now been placed on this kind of period before pregnancy as well, in terms of trying to understand how we can improve the health of adults in those reproductive years, whether they go on to conceive a pregnancy or not. There are certainly some gains that could be made.
Yeah. So basically, I'm just picking up on the text messaging. I mean, you're just doing constant, reminders to carry out the tips. So you're not just sort of like carrying out the tips yourself and filling out your self-monitoring sort of sheets or apps or whatever they might be. You're actually sort of like text, you're getting a message to, I mean, we had that a lot, people, when I did my ATI, which was a repetitive trait intervention study as well. It's just, again, it wasn't even a feasibility, but you're trying to, getting the people to remind them to do stuff does help, and very likely in the habit formation.
Yeah, exactly. So the text messages were thought to be a sort of an additional prompt for behavior. We've coded some of the behavior change techniques within those text messages. So the message in itself, I suppose, served as a prompt or a reminder, but dependent also on the context of and the content of that message, there may have been additional kind of behavior change sort of components within that. So sometimes they ask participants to do enter into a two-way, text back yes for this or no for that. They weren't, they were automated, so it wasn't personalized as such.
Yeah.
But they were all personalized to the level of pregnancy that they're at, and made specific for their timeline, but they weren't tailored as such in that personalized way as the researcher on the other end. But we've had some early qualitative feedback, and it's been very positive really for that, and also for the HIP-B, the sort of non-text messaging intervention as well. So I guess we'll see what the results say, but certainly at this stage we feel pretty confident that women found it acceptable, and did enjoy that process. And who knows whether we'll see in the data whether the text messages added a layer to sort of help with that level of behavior change or not. It's a chaotic time in pregnancy. Even if it's a first pregnancy, a lot of the women involved in the studies were in an interconception period as well. So they had already maybe one or more children, and then this was a subsequent pregnancy. So again, that means things become even more challenging in terms of your own health and trying to remember what to do and when to do it. So yeah, we'll see whether the text messages helped in any way.
I mean, what's interesting is that you're taking the work and you're trying to set it up. I mean, because essentially what you would want is to be able to set it up on a sort of like national scale. I'm going for big, okay, national scale, so that you do have this sort of preconception, obviously conception, pregnancy, and then postpartum, sort of across that stage, proper sort of guidance for women, and that material is available, to be able to follow through, and then maybe with help from, sort of the medical system in a way that it can be delivered.
I think that's it. I mean, there have been a lot of discussions actually at our end recently about what next, because we are coming towards the end of this trial, and it's at the feasibility stage. So there will ultimately, we will want a follow-on multi-site kind of randomized controlled trial. But because of the different implications that COVID has had and some of the pragmatic changes that have had to occur, we maybe have a different set of data than we initially thought we might have at this point. Still very rich and still very useful, but slightly different. And I think that what some of the feeling that we've had from looking at, some of the qualitative feedback so far is that maybe, yes, there's different levels of intervention that can be useful for people. So almost on a kind of stratified risk basis. So maybe if you enter pregnancy at a BMI of 25 to 28 or up to 30, you could have some kind of app-based or, text message-based service that was pretty well automated. Maybe it had some videos or one consultation or something like this kind of HIP-B study or the 10 top tips with a face-to-face health professional. But maybe for the most part, that could be delivered remotely. And maybe that's enough. That brief intervention is enough in that group. But maybe as, weight or additional weight becomes more complex, or if obesity is more, challenging to manage and there are other comorbidities, maybe there's a different intervention that's needed, or perhaps that can still form the 10 top tips, or the HIP-B intervention could still form the basis of that kind of intervention, but that it requires additional input, and so those are some of the discussions actually that we're having at the moment. So yeah, quite apt that you asked.
Well, I'm glad, because it sounds like you're going to be kept busy for a while. Is there access to these tips from the HIP-B?
Hippie, no, not at present, because we're just in the final stages of the initial feasibility trial. Yeah, I mean, the 10 top tips for a healthy weight is available online as a leaflet.
I've posted those, yeah.
Oh, perfect. So, and they are somewhat similar. They're not very far removed, but obviously they're just adapted for pregnancy. So unfortunately, they're not available to share more widely at this point in time, but we are in the process of writing an intervention development paper. So watch this space.
Yes, we will.
And then hopefully it will be available in due course. Yes.
I don't want to put you on the spot anymore. We need to be for those sort of things. I just want to touch a little bit more on the whole sort of weight bias and stigmatization of, weight during pregnancy or before pregnancy. Like what do you get? What have you seen? Oh my God, you want to get pregnant and you're that weight? Sort of comments, or what do you get?
It's really, really challenging area, actually. We've been doing some research on this area of weight stigma, and we've my PhD student who's just graduating actually at the end of this month, again is working on a paper, so that will be out very soon. And we sent out a survey, and sometimes with the kind of survey you don't expect these very rich, detailed responses, and some of the responses, in fact most of the responses that we got back asking people about any experiences of weight-based discrimination and so on that they'd encountered either just as an adult or in the context of pregnancy. I mean, honestly, it was harrowing reading. And, we all found it quite challenging sometimes going through the detail that had been conveyed by participants on this, as I say, online survey, which you wouldn't have expected such rich sharing of their personal experiences from. And, everything from just equipment not being right, not having a blood pressure cuff that, will fit a lady on the arm during pregnancy, or comments from, maybe a sonographer who is having trouble seeing what they need to see in terms of the scan, and makes reference to, because of additional weight that a woman might be carrying. And these comments were not isolated incidents. I mean, this was a really common find amongst the data, also things like, even to the very far end of the spectrum where women felt they couldn't continue with a pregnancy because they were so fearful of the risk that they had put an unborn child at because of their excess weight. So really, very emotionally laden area, a lot of care needs to be given, I think, to any research that's done in this area, and especially around the framing and the terminology that's used. So we spent a lot of time working with women and with lived experience, as I say, of overweight and obesity in pregnancy. And so they've helped us to draft the leaflet and make it clear that it is very non-judgmental about, women. And, when they enter pregnancy, there was a really recurrent theme that a lot of women who enter pregnancy at a higher weight feel very guilty for that, for being at a higher weight, and, do still feel blamed by healthcare professionals, unfortunately. I mean, obviously there were some instances of excellent treatment, but on the whole, there were also some, I would say on balance, a lot of negative experiences with healthcare staff. So one of the things that we've taken away from this piece of work is that, when we even go in to implement a trial, for example, like the Hippie study, we were training the staff directly involved in the intervention, for example, in terms of approaching women about a study like this. And we were training them in terms of terminology and wording and, how to raise the issue of weight sensitively. But what has come through, I think, actually from some of our process evaluation work on it all, is that probably needs to be extended to the whole maternity department. I mean, I don't think that, I think it's a good idea for any healthcare staff really to update their training and so on a regular basis. And the issues around weight-based discrimination are coming through sort of really clearly more and more.
Yeah.
So I think, sorry.
Not just pregnancy, I mean, just in the health system.
Absolutely. Yeah. So we were thinking that, an outcome from this would really be that we would want, an adoption, almost like when you talk about a school doing a healthy eating initiative, that it's a whole school approach, for this kind of intervention in the future. Maybe it needs to be a whole maternity antenatal service approach, that there really needs to be that level of commitment, I think, from the top down in terms of thinking about, the way it's framed in terms of how to better help women manage their weight. Because as one lady put it in one of her quotes, I'm already pregnant and, you're telling me I can't lose weight in pregnancy. So don't blame me for feeling like I have excess weight then, because she can't lose weight now. We're not recommending in pregnancy you lose weight. So it's about trying to support women to, reduce the risk of any harm and improve their nutrition, improve their physical activity behaviors within those safe limits as much as possible, and to really have some, evidence-based support around that. So that's really been the aim of that.
Yeah, that sounds, well, please let us know when that paper comes out. I'll be sort of keeping my eye out, because I would really like to, to see those results and read those results. That sounds really interesting. Wow, sure. Laura, what is there anything else that, I mean, I know we could talk here for a long time about a lot of things. Is there anything else you'd like to sort of wrap up with that just sort of says, what, anything else that might just sort of like link this whole intervention across the reproductive years? And
I think some of the newer work that we're doing on the pre-conception period, so that pre-pregnancy period. I have a PhD student now, Emma, who's working diligently on that. And actually what we've managed to do is to get access to routine maternity services data for all women in Northern Ireland across sort of a decade or more. And so we're just in the early phases now of trying to really interrogate that data to try and look at some of these kind of preconception or early pregnancy risk factors. So, where do we need to be focusing? Is folic acid still a big issue? For example, we know that levels of overweight and obesity are still a big issue in the preconception period, in the interconception period, and, for adults generally. So, that some of that work will really help us to kind of focus in. Although the women in this data set will be pregnant, they get asked questions at that first pregnancy appointment about their lifestyle prior to pregnancy. So aside from some, issues around recall bias and so on, we might be able to paint a little bit of a picture about sort of preconceptual health as well as that of early pregnancy. And I think that really understanding that reproductive life course, thinking about those different phases and segmenting the message, I think that, there will be a need to, subgroup people or categorize people to an extent into, there are people who are actively planning a pregnancy, for example. So, they may need or be ready for a different kind of evidence-based intervention that's much more targeted, whereas there are probably general population messaging around, raising this issue of health before a pregnancy that is important for the whole population, especially given the high rates of unplanned pregnancies that we have here. So, people may not intend to conceive a pregnancy, but we know that most people who do conceive here, or at least half of them at times, it was maybe mistimed, for example, not intentionally planned. So, that's why improving the health of adults in these reproductive years more generally, I think, is also still an important thread throughout all of this work, as well as those more kind of targeted intervention developments for people, for example, who are actively planning or who are pregnant and so on.
Fantastic. Yeah, I'm really impressed with all the work that you've done, Laura, and it just I think it gives us all a lot of ideas as to where to go as well in this area. I think we all, well, I know I work as well with some of my master's students who are doing work with pregnant women and stuff. So this is really interesting food for thought. And thank you for linking, the intervention, all the theory-based, the habit-based, and how just simple it is to be using these techniques. In a way, it can be so simple to deliver and can potentially be so effective. So yeah, thank you very much for your work. I will
My pleasure.
Your Twitter account here so that people can get hold of you as well, and through the university as well, your email.
Sure.
Just in case anyone is, interested. And I'll just remind everybody that, please like, comment, subscribe to the channel, and forward this episode as well to those you might think will be interested in hearing about this topic, so that you can just help this community grow, because we're literally trying to disseminate, science, but behavior change as well, mainly. So thank you, everyone, for being here with us on this episode of Alimentos y Emociones podcast. Thank you, Laura, so much for being here with us today. And
thank you.
I remind everybody that we continue to nourish each other. So see you soon. See you next time.
Thank you.
Bye.
Thanks very much. Bye.
Gracias por escuchar un episodio más de Alimentos y Emociones podcast. No olvides dejar un comentario, suscribirte al canal y presionar el botón de notificaciones. Ayúdanos a crecer. Y recuerda, nos seguimos nutriendo.